Yeah, please.
Yeah, good morning all. I would like to thank AIOS for giving me this opportunity to address your August gathering. So I'm speaking on ensuring patient satisfaction, a pre-op fundus examination. Cataract is one of the leading causes of visual impairment. Pre-op evaluation is crucial. Like ocular surface disorders, if not addressed pre-surgery, they will lead to an unhappy patient. So fundus examination should be a must-do in optimizing the post-op results. Why so? We have evolved from ICC to ECC to SICS to minimal incision cataract surgeries. From local to topical anesthesia, from monofocal, we have a myriad of lenses, multifocals, trifocals, extended depth of focus. So in the era of femtosecond lasers, wavefront technology, intraoperative aberrometry, focus is not just 6/6. So why do we need to examine the fundus? To assess the retinal and optic nerve health, to exist coexisting pathologies like diabetic retinopathy, ARMD, RD, glaucoma, for an accurate visual prognosis and patient counseling. What are the challenges in cataract patients? Mediopacities can obscure the fundus view. Dense cataracts make visualization difficult, so we need alternative imaging. Fundus can be examined by direct, indirect ophthalmoscopy, a slit lamp biomicroscopy with a 90D or 78 diopter lens, a B-scan ultrasound in dense media opacities, by OCT scanning, fundus photo, wide field photo, OCT or Opta. B-scan is indicated when the fundus view is obscured. It's useful in dense cataracts, suspected retinal detachment, intraocular tumors, and vitreous hemorrhage. The common findings which impact prognosis: macular scar, there'll be a poor visual recovery post-op. In optic atrophy, there's a limited visual potential. In AMD, the patient may complain of distorted vision or limited improvement. DME needs treatment before or with cataract surgery. So let's come to some examples. We had the 60-year-old female came to us with a vision of 618. On pinhole, she improved to 6/9 parts. Had fundus not been examined, had OCT not been done, who would be responsible for the poor visual recovery after cataract surgery? So she basically had a lasered BRVO with an ERM with a lamellar macular hole. She was given an option of a combined surgery versus cataract and observation. She chose only cataract surgery. We observed for the ERM for now. Another 65-year-old female came with significant cataract. On examination of fundus, she had an ERM with lamellar hole epiretinal membrane proliferation. So she was advised a combined cataract with vitrectomy. Another 55-year-old female, recently diagnosed diabetic. In the right eye, she had 3/60. On pinhole, she was improving to 618. The other eye on pinhole improved to 636. We examined fundus, did the OCT. Right eye showed retinal thinning, which was suggestive of macular ischemia, while the left eye there was ERM with VMT. Another 56-year-old female, high myope, came for the clear lens extraction. On fundus examination, the left eye showed asymptomatic polyps. She had a tall, peaked, heterogeneously reflective PED. She would advised anti-VEGF followed by cataract surgery. Another patient, he had a scarred CNVM, so was undertaken for cataract surgery after explaining a guarded visual prognosis. So let's come to specific cases. Cataract surgery in diabetics. We all know diabetics develop cataracts early. The most common type is senile. Snowflake cataract can be seen. Patients who have a pre-existing untreated PDR, they are more likely to progress, develop vitreous hemorrhage after cataract surgery. Therefore, PRP is recommended preoperatively if the media allows. If not, these days we give anti-VEGF after ruling out tractions. Combined cataract surgery with PPV may be undertaken for cases with a dense VH, macula threatening or involving TRD, combined RD, taut posterior hyaloid. In patients with pre-existing DME, cataract surgery increases the risk of progression or redevelopment of macular edema in about 20 to 50% of cases. So therefore, it should be adequately treated before surgery with anti-VEGFs or steroids. Dex implant has shown a significant improvement in CSME over 3 years. A lot of studies are available. Another study which highlighted that the risk of DME progression was seen in almost all grades, about 1% in no DR, 5 to 13% in the various grades of DR. DME increased sharply in first year after cataract surgery. Post-op CME chances are also higher in these patients, so pre-op use of NSAIDs may reduce these chances. Hydrophobic acrylic IOL has the least chance of PCO. and silicone oil adhesion, so should be the IOL of choice. In patients with PDR but with an NVI, they need prompt treatment to induce regression of NVI with anti-VEGF with PRP or cryo. Phaco should be considered with PPV at the earliest, with or without PPV, to enable adequate treatment of the posterior segment pathology after regression of NVI. Combining Phaco-Trab may be planned in cases with coexisting NVG when NVI has regressed. So this table summarizes very well. In patients of no to mild stages, standard Phaco can be done. Moderate to severe, Phaco with pre-op NSAIDs. Mild to severe NPDR, but DME is present, first treat anti-VEGF. In PDR, with or without DME, anti-VEGF, PRP, a combination may also be indicated. Coming to peripheral retinal degenerations, degenerations which predispose to RD are lattice, snail track, degenerative retinoschisis, tears and holes. Lesions which predispose to RD in a patient with recent onset flashes and floaters should not be ignored. Lesions predisposing to RD in patients undergoing refractive, cataract or intravitreal injection should be treated pre-op. And a patient advised for refractive surgery, check for PVD symptoms. If they are present, treat if you detect lesions. Defer the refractive surgery, treat only after 2 to 3 weeks. This also summarizes the preferred practice pattern, that lattice degeneration but with no flashes, floaters but undergoing intraocular surgery should be treated before. Retina examination prior to intraocular surgery or laser or intravitreal injections. Everyone should undergo a dilated fundus examination. Peripheral lesions need to be treated and the procedure can be undertaken after 2 weeks. So I'll conclude by saying, avoid multifocal or extended depth of focus IOLs in patients with macular pathology. In patients who are undergoing premium surgeries, do an OCT invariably. And as the age goes, if we diagnose it before surgery, it's the patient's problem. But if we diagnose it after surgery, it's our problem. Thank you.